All right, so thanks everybody for coming, you guys. The first roundtable of 2022, so thanks for joining us. We've got an excellent lineup of presentations for you guys. So we're going to get started with Sarah Haddleton, who's going to talk to us about trauma-informed care in the ICU.
Good morning, everyone. My name is Sarah Haddleton. I am a ICU nurse at Vancouver General Hospital, and I'm here today to talk to you about a project that we're working on, which is looking at trauma-informed care in an ICU setting. I'd like to begin today by acknowledging that I live and work on the traditional unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh Nations. And I'd also like to thank the BC chapter of the CACCN for offering me this opportunity to share this project that we're working on. I have no disclosures, but just a caveat that I'm a learner. This is my first time doing anything like this, engaging with knowledge translation, and I'm working on my own knowledge about trauma-informed care and how to be more trauma-informed in my approach as a nurse in the ICU care. So some introductions. Like I said, we're participating in a knowledge translation challenge. And our project is focusing on integrating the principles of trauma-informed care into our ICU at VGH. This came about, I had an experience initially when I was doing my critical care training program through BCIT and VGH with a patient who had come in for a repeat procedure. So this individual had come in for a repeat procedure, and I cared for them for 2 days in a row. And I think somehow in the course of our conversation, it came up that this person had received excellent care. They described it as that excellent care in the ICU, but that the hardest thing for them in going through this repeat procedure was not the procedure itself or the aftercare, but the actual experience of being in the ICU. And they use the word trauma that they had experienced despite everyone being caring and kind, and providing excellent quality care. And so that really stuck with me. And then I did some reading about trauma, and I was thinking about how to incorporate it into my own practice. And then I realized, we do everything better as a team in ICU. Why was I trying to do this on my own? And so I reached out to some colleagues, and they agreed that this would be a really interesting project to take on. And so we put together a presentation for the knowledge translation project, and we're waiting to hear back from them about whether they'll be moving forward with funding our project in our ICU. Our team members include Alana, whose screen I'm presenting from today, her office, and then Jess, one of our CNEs in ICU, Simi, a former CNE and now regional educator, and then our social worker in ICU named Savannah. And then we've reached out some other people, including Aboriginal Health within Vancouver Coastal Health. We are looking at partnering with some physiotherapists and some respiratory therapists and looking to really provide a comprehensive look at trauma-informed care in an ICU setting. Also, 2 articles came out recently of note in the light of the pandemic, looking at trauma-informed care in an ICU. And they're both position papers saying that the ICU can be a traumatic place and can trigger traumatic responses in individuals, and we should look at integrating this more completely through ICUs as a whole, especially given the sort of prominent awareness of ICU care in the light of the COVID pandemic and seeing more ICU in the media. So what are we doing? We're doing a KT challenge. We're looking at trauma, and we're looking at trauma-informed care. So what is knowledge translation? So knowledge translation, this was new to me, but so that it's the idea of translating art and science and moving evidence that already exists into our day-to-day practice. It's sort of an iterative process. It's dynamic. It involves looking at the body of literature and then synthesizing that and moving the key takeaways forward for us. This challenge at Vancouver Coastal Health is in partnership with Providence Health as well as BC Cancer Agency, and it's designed to support people like myself, a bedside practitioner, into increasing our capacity and sharing information that we think is relevant or might impact our practice. The next definition I'd like to talk about is trauma. And this definition comes from CAMH. And I think it's a really simple but elegant way of describing trauma. It's the emotional response when an injury overwhelms us. Our social worker just referred to it as a wound, like it's an emotional wound. It's an individual's, when experiences overwhelm us. This is also from the Trauma-Informed Policy Guide put out by the BC Centre for Excellence in Women's Health, experiences that overwhelm an individual's capacity to cope. Trauma can be a single incident, it can be a complex or repetitive instance. We also see developmental, intergenerational, and historical trauma, and all of these definitions are well defined in the literature, and all of them can exist in the history of our patient and might not be known to us when they come into an ICU. And one of the key features of trauma-informed care is that they don't need to be known to us. We can apply a trauma-informed lens to all of our patients and all of the care that we give in order to minimize the risk of re-traumatizing the patients who come to us. So responses to trauma can vary from person to person. Like many things that we see, they exist on a continuum, from minor disruptions to debilitating responses. We see documented responses that occur in both physical and mental health. Things like anxiety, terror, shock, shame, emotional numbness, disconnection, intrusive thought, nightmares, depression, PTSD. And then in terms of physical health, things that have been reported, trauma survivors may experience things like chronic pain, gastrointestinal problems, asthma, heart conditions, musculoskeletal difficulties. We see autoimmune disorders related to the responses of trauma. And then in addition to these physical and mental responses that are well documented, we can also see physiological adaptations that people develop in response to trauma that result in sort of what is termed an underlying state of dysregulation. And with that dysregulation, it leads to challenges in processing emotional reactions that ultimately compound the initial trauma and perpetuate the mental, emotional, and physical distress of the trauma, and ultimately impact an individual's sense of safety and then the way that they can interact with the world around them. The other key point is that age plays a significant role in how trauma is processed, and early childhood trauma can have especially negative consequences that may not manifest until later in life, but does ultimately have some effect on the neurotypical development of the brain. There's a big study that came out of the States called the Adverse Childhood Event Study, and that looked at experiences of children age 0 to 18 and quantified these different levels of violence or abuse or neglect. Did individuals witness violence at their home or in their community? And what they found was that about 61% of adults who were surveyed across 25 states reported experiencing at least one adverse childhood event before the age of 18, and nearly 1 in 6 individuals reported 4 or more of these instances that had greatly impacted the course of their life. Subsequently, the CDC went on to look at all of this information and came to the statement that by preventing these adverse childhood events, we could alleviate the burden of disease in our communities. And they have suggested that they could alleviate up to 1.9 million heart disease cases and 2.21 million instances of depression could have been potentially avoided by preventing or minimizing these adverse childhood events. So all of this is to say that trauma is very common. And some Canadian examples, 76% of Canadian adults report some form of trauma exposure in their lifetime, and 9.2 of those adults met the criteria for a diagnosis of PTSD. It's estimated that 50% of all Canadian women and 33% of all Canadian men have survived at least one instance of sexual or physical violence. And in terms of our homeless population, through BC, we looked, there was a statistic that looked at 3 BC communities and interviewed individuals. 51% of these individuals reported some instance of sexual abuse. 55% reported reported physical abuse. 60% reported neglect. 58% reported some kind of emotional abuse. And again, 57% of these individuals met the criteria for current PTSD. So knowing all that brings us to a trauma-informed care approach. And the tenets of trauma-informed care ask us to understand the prevalence of trauma, to recognize how trauma affects individuals. And then once we know this, to put our knowledge into practice, to ask us to work at the client, the staff, the agency, the system level to address the core principles of trauma-informed care, which are awareness of trauma. Do my actions facilitate safety and trustworthiness? Can I offer my clients choice and collaboration in how I work with them? And can I work with them in building on their strengths and skills to help them move to a place where they want to be? A key point to mention here is that trauma-informed care is not about replacing good practices, but rather about building on what already exists, refining our lens, strengthening our practice, and strengthening our programs. And so the outcomes of trauma-informed care are well documented in several disciplines. Specifically, mental health and substance use disorder literature really focuses on this approach. And a lot of the research that I have found to date and read through from this discipline shows us that using a trauma-informed approach can help us to facilitate trusting relationships with our clients. It ultimately works to improve individuals' long-term health outcomes, and it minimizes the risk of us traumatizing already traumatized individuals. The mental health and substance use literature really reflects a decreased use of restraints, decreased use of seclusion time, and a decreased negative sequelae of re-traumatizing individuals, and subsequently individuals coming back and having more interactions with healthcare in a positive way that ultimately go on to increase the quality of their lives. Trauma-informed care is also actually associated with positive outcomes for the staff who learn about it and utilize it in their practice. It's associated with decreased cognitive dissonance, increased staff satisfaction, increased organizational commitment, and potentially promoting the retention of staff in environments. So knowing all of this, we put together our presentation for the KT Challenge, and this is our context. So depending on where you read, somewhere between 60 and 76% of adults experience one or more traumatic event in their lives, and that's just individuals who are reporting. 22% of patients who survive a critical illness and an ICU stay go on to experience some form of post-traumatic stress disorder. We also see high instances of PTSD in next of kin who are temporary substitute decision makers or just visiting their family in an ICU. We know that patients with a history of trauma will often experience re-traumatization with subsequent experiences with healthcare. And there tends to be a higher prevalence in lower income communities. So although traumatic events occur in all racial, geographic, socio-demographic groups, we tend to see higher instances in lower income communities. Subsequently, not using a trauma-informed lens or a trauma-informed approach may perpetuate disparities in critical care delivery. And many seemingly benign situations can actually be traumatic. So even though we don't see like an instant reaction, the consequences can be widespread, hidden, and latent, and may manifest themselves at a future incident that might be traumatic for an individual. Trauma-informed care will facilitate trusting relationships between healthcare providers and patients. Trauma infects people indiscriminately. So it's also important to consider that not only might our patients be experiencing trauma, but it's reasonable that healthcare providers, the individuals who are looking after traumatized individuals, might have their own trauma that could be exacerbated by the experiences that they're having. And then trauma-informed care has been associated with increased staff satisfaction. So what are we doing? Well, we're going to start with this threefold approach with our KT challenge, which begins with a need assessment and stakeholder engagement. Our ICU has a very strong patient and family-centered care lens, but there's no mandatory training for a trauma-informed approach. And this might leave some people unfamiliar or unaware of this approach. The people that I work with, I think practice with an innate awareness of what trauma-informed care is because I've seen it. I've seen the caring, compassion, and excellent care that people provide here on a daily basis. But I think people might not be able to articulate it from a trauma-informed lens. So what we really want to do is find out what people know and then support formalizing of trauma-informed care within an ICU setting. A key aspect of trauma-informed care is to understand that trauma affects people differently: men, women, children, immigrants, refugees, people with neurodiverse development, Aboriginal people, and racialized populations. So we are working to engage a diverse group of stakeholders who can elucidate like all the subtleties of this experience for us and help us to provide a really comprehensive intervention tailored at supporting trauma-informed care approach in our ICU. We are also working to engage a patient partner in hopes that that will also strengthen this intervention. So after our needs assessment, we will progress to our KT activities, which will be delivered through ongoing unit huddles, staff meetings. There's an excellent Alberta eHealth trauma-informed care 6-module learning tool on Learning Hub, which takes about 6 hours, but has some really strong information in there. And if anyone is interested, I would encourage you to try it out. We'll also be hosting a trauma-informed workshop or a brunch and learn at some point in time to engage in discussion with our staff members here and see how things are going. And we'll be administering sequential surveys as we move through. And then our final piece of this puzzle will be sustainability activities. So in one of the KT workshops I attended, they said, you don't want to teach people something. What they didn't want was a hope, like a teach and pray situation. So you don't want to tell people something and then hope they incorporate it into their practice. You want to offer them sustainability. So we'd like to incorporate this into all new hire orientation and include a trauma-informed care section in all ongoing unit orientation. So when you do your burn orientation, when you do your CRRT, what are some ways that we can incorporate the principles of trauma-informed care into this ongoing learning so it becomes iterative, so it becomes didactic? And that's it. That is all I think I have to say.
That was amazing, Sarah. Thank you so much for your presentation. We definitely, I think I learned a lot from you for sure.
Oh, thank you very much.
Thanks for watching, everyone, and thank you for joining us on the BC chapter of the CACCN YouTube channel. I would suggest subscribe and hit the notification button so you can know when the next thing is out. And if you ever want to come to our next event, we're on Facebook and on Instagram. Our links are listed below. And while I'm on the topic, if you're a critical care nurse anywhere in Canada, why don't you join CACCN? We have a ton of resources to help you be the best critical care nurse you can be. Go to caccn.ca and join us.